Hi, I'm Shivaraman. I'm an assistant professor in radiology at Johns Hopkins, and I'm going to talk a little bit about the CT evaluation of GI bleeding. And specifically, we'll talk about why we do these studies, how we do these studies, and how you should go about interpreting these studies in your own practice. Now, I think it goes without saying that acute gastrointestinal bleeding is a pretty common medical emergency. So this is something that ER physicians deal with all the time. It accounts for somewhere in the order of 1 to 2% of all medical admissions, and the mortality is actually quite significant, with as much as 40% mortality in patients who have bleeding with associated hemodynamic instability. Now, most cases will actually cease bleeding spontaneously, but in those patients who rebleed, which occurs in about 25%, there is a much higher risk of significant morbidity and mortality. Now, from a definitional perspective, GI bleeding can be broadly divided into two types. There's upper GI bleeding, which occurs proximal to the ligament of Treitz, and then there's lower GI bleeding, which occurs distal to the ligament of Treitz. And each of these two forms of bleeding is associated with its own unique form of clinical symptomatology. Now, that being said, even though in most cases the physician will be able to tell clinically whether it's an upper or a lower GI bleed, there are going to be cases where it's more ambiguous and where you're not going to be certain where exactly the bleeding is coming from. Now, upper GI bleeding tends to be associated with a relatively small number of pretty common causes: ulcers, varices, gastritis, duodenitis, Mallory-Weiss tears in alcoholics, and very rarely malignancies. Now, lower GI bleeding, on the other hand, which is really what we're going to be talking about the most here during the course of this lecture, has a large number of different causes, maybe about 20 to 30 different causes that you're pretty commonly going to see in clinical practice. And these range from diverticular disease, vascular malformations, angiodysplasia, various forms of colitis, malignancies, anorectal disease, and even small bowel disease. And many of these are going to be diagnosable based on a CT scan. Now, I think it's worth noting before we go any further that any patient with a suspected upper GI bleed, so if you have clear clinical symptoms that suggest the bleeding is coming from proximal to the ligament of Treitz, there is really no role for CT in these patients. Anyone with a suspected upper GI bleed should go straight to endoscopy, which is proven in the literature to have very high sensitivity and specificity, facilitates diagnosis, and is going to allow treatment in the vast majority of patients. Now, even in those cases where you're not certain whether it's an upper or a lower GI bleed, then you're still not going to go to CT. You're going to put in an NG tube, you're going to do a gastric lavage, and if there's no blood in the aspirate, then you know you're probably dealing with a lower GI bleed, but if there is blood in the aspirate with hematemesis, then you're probably dealing with an upper GI source. But regardless, patients where upper GI bleeding is a possibility should not undergo CT. Now, when you're dealing with lower GI bleeding, on the other hand, I think there's a lot more ambiguity about what really is the best course of action. Now, I think no one would argue that any exam should start with a digital rectal study and a proctoscopy just to exclude anorectal causes of bleeding. But beyond that, there are a number of different options, and I think you will find different clinicians, different radiologists who will come down on different sides of the debate. Which of these 5 studies really is the best next step? Colonoscopy, nuclear medicine, angio, video capsule endoscopy, or CT? Now, traditionally, people have said that it's colonoscopy, and that's certainly what I was taught as a resident. I was taught that there's really no indication for CT in patients with lower GI bleeding, and that everyone should go straight to colonoscopy. I was taught that it was sensitive, that it was specific, that it was safe, and that it would facilitate treatment. And all of that is relatively true to a point. The problem is that it's great in the outpatient setting, right? If you have a patient who comes into the outpatient center, it is very sensitive, very specific, the patient has had a bowel prep, no problem. It's a safe study and you can facilitate treatment. The problem is that we're not talking about an outpatient setting when you're dealing with a patient who comes in with emergent lower GI bleeding. These patients haven't had a bowel prep, there's blood everywhere obscuring the mucosa, very difficult to figure out where the bleeding is coming from. And so at the end of the day, the sensitivities and specificities reported in the literature are far lower in practicality in the acute ER setting. On top of that, we all think of colonoscopy as being a safe procedure because we go ourselves, our parents go to get a colonoscopy, and there's really no problems. The problem is that the mortality rate is actually not insubstantial when you're dealing with the ER setting, with complication rates as high as 2% and mortality rates of about 0.3%. Now, putting all of that together, I think there is a real question as to whether colonoscopy should be the initial best step for a patient with an acute lower GI bleed. Now, what about a radiology study? Nuclear medicine, tagged 99M, technetium 99M labeled RBC scan. Now, this is what we were all taught was the best radiology study, right? Very sensitive, can detect bleeding as low as about 0.1 cc per minute, non-invasive. You can scan over time, which allows you to detect slower bleeds or intermittent bleeds. And it is very sensitive for both arterial and venous sources of bleeding. Now, I'm not going to argue with any of that. It is a good study. The problem is that it doesn't give you a whole lot more information, right? It can, in some cases, tell you, yes, there is a bleed, no, there's not a bleed, but frankly, you knew that already, right? You know the guy has bleed, you know the patient has bleeding. What you really want is more information. You want to know, where's the bleed coming from? Why is the patient bleeding? And that's information that nuclear medicine can't give you, right? In many cases, you are not going to be able to accurately localize where the bleeding is coming from, largely as a result of the poor spatial resolution of the study inherently, but also because of bowel peristalsis, particularly in the small bowel. And on top of that, it's not going to tell you, well, does this patient have a tumor? Do they have an AVM? Do they have angiodysplasia? It's just going to tell you that they have bleeding. So putting all that together, again, I think there's some debate as to whether this is really worth the effort. Is this a study that should really be the first-line study out of the emergency room? What about catheter angiography? Now, there's little doubt that this is a great study for treatment. At least as good as colonoscopy, maybe better. But I think there's, again, very little doubt that this is not a good first diagnostic modality. Of course, you're dealing with an invasive modality that has its own associated risk of complications, including bleeding. It is not that sensitive, can detect bleeds only that are relatively brisk, perhaps about 1 cc per minute. And on top of that, even when there is a bleed, it can be very difficult because of its poor contrast resolution to accurately localize the site of bleeding, especially when you're doing a non-selective injection. You're going to catch arterial bleeds, but you're generally going to miss venous sites of bleeding. Now, putting all that together, this is not an appropriate first-step diagnostic modality. It's a great test for, or it's a great modality for treating, but shouldn't be used for diagnosis. Now, I think this goes without saying, but I think it's worth reiterating. Video capsule endoscopy is not appropriate in the acute setting, period. It's a great test for occult chronic GI bleeding if you want to find an occult tumor, occult inflammatory bowel disease, an occult erosion, something else that's chronic in nature, great, good study. But that being said, it is not an appropriate test in the acute ER setting, and certainly, hopefully, ER physicians are not ordering these in the acute setting. So, putting all that aside, we've talked about 4 modalities, and I've given you a sense for why I think they are not the optimal initial test to perform. Now let's talk about the test that I think should be the initial step, and that's CT angiography. Now, let me preface this by saying that we started doing these studies widely at Hopkins maybe about a couple of years ago, maybe 3 years ago, and I first thought it was ridiculous. You know, I'd been trained as a resident and a fellow to think that, okay, we should be doing colonoscopy. Why are we doing these CT scans again? Aren't we just wasting time? Are we actually ever going to be able to make a diagnosis that's going to help a patient? But honestly, over time, as I've seen more and more of these cases, I've come around. And I now truly believe that patients with lower GI bleeding should always start with a CT scan, especially when they're hemodynamically stable, and that it is certainly a better initial diagnostic test than any of the other alternatives I've talked about earlier. It's widely available. Any ER in the country is essentially going to have a CT scanner. You don't need any special training either for the radiologists or for the technologists to perform the study. It can essentially be performed easily using standard protocols on any modern CT scanner. It's relatively sensitive. So you can detect levels of bleeding that are certainly much better than angio and not that much worse than a tagged RBC scan, perhaps as low as 0.35 cc's per minute. It is quite sensitive. So you can identify sites of active extravasation, but I think most importantly, even in patients where you don't see an active site of extravasation, you can see other bowel pathology that can explain the patient's bleeding. So maybe I don't see active extravasation of contrast, but I may find a tumor. I may find angiodysplasia. I may find bowel ischemia. So I think it gives you so much more information than any of the other modalities I talked about. Now, like any test, there are disadvantages, but I think they're relatively minor. Yes, there's no option for therapy. Yes, it carries the risks associated with IV contrast and radiation dose. And optimally, you have a patient who's actively bleeding during the study. But I think the biggest disadvantage of the study is when you have a radiologist who's reading the study who hasn't looked at many of them and isn't familiar with some of the pitfalls. So I think the most important thing when you're doing these studies is to make sure that you're familiar with how to interpret the studies and what to look for so that you don't either overcall a bleed or undercall a bleed. Now, how do we do these studies at Hopkins? Now, it's important to note that you need to have at least 2 phases. Now, some institutions will acquire non-contrast and arterial phase, whereas others will acquire arterial and venous phase. And that's what we tend to do at Hopkins. We get arterial and venous phase images typically at 25 to 30 seconds and 50 to 60 seconds respectively. Now, why do you need 2 phases? And the reason is that you want to be able to differentiate a true active site of bleeding, active extravasation, from high-density ingested material that's sticking around in your bowel, right? And we've all seen cases. We've all read CT. You've seen old barium, suture material, medication, and all of that, if you're just dealing with a single phase, can easily be mistaken for active bleed. When you have 2 phases, you should be able to make that distinction easily. Now, it is important when you're doing these cases that you inject as fast as you can. The faster you inject, the more likely you are to find active extravasation. So I would say 120 cc's of contrast, at least 4 to 6 cc's per second. Now, it goes without saying you can't give positive oral contrast, right? If you do that, you're going to have a non-diagnostic study. That positive contrast is going to pool in the bowel. You're going to have no idea whether there's a bleed there or not. Finally, it is important that you don't just rely on the axial images. 3Ds, especially MIP reconstructions and multiplanar reformations, are critical for maximizing your odds of catching a subtle bleed. And believe me, I'll show you some cases during the course of this lecture. The bleeds can be quite subtle, and if you're just relying on the axial images, it can be very easy to make a diagnosis, or very easy to miss a diagnosis. Now, it is worth noting, even though we're going to concentrate mostly on acute GI bleeding, the protocols for chronic GI bleeding isn't much different. Again, you're going to be doing dual phase studies, arterial and venous phase images at about 30 and 60 seconds, brisk injection of contrast. But in these cases, you're not looking for active extravasation, but rather you're looking for chronic occult sources of bleeding, which are going to include chronic inflammatory bowel disease, maybe an occult small bowel tumor. So in these kind of cases, you actually do want to give contrast to distend the small bowel, and so you're going to use an enterography protocol. So typically you're going to give volumen, although there are some other options out on the market for distending the bowel with a neutral agent. Now, these neutral agents have a relatively low attenuation, usually less than or about 20 Hounsfield units. So they're going to distend the bowel, but still allow you to evaluate the wall for both thickening and for abnormal enhancement. And by the same token, they're not going to interfere with your 3D post-processing. Giving positive contrast can be a real problem in these patients because you get so much streak and beam hardening that you're not going to be able to make subtle determinations about abnormal wall enhancement or very subtle sites of wall thickening. Now, I'm not going to go into a lot of the details in terms of our protocols, but I will say that Dr. Fishman has put our standard GI bleeding protocol for a number of different scanners up on ctss.com. So I would strongly recommend that if you plan on implementing this protocol at your own hospital, just take a look at his protocols. They work really, really well. And honestly, our image quality for these studies is exceptional. And I think that we've found the study to be very sensitive and specific. And our clinicians have really bought in. Our ER physicians now order this study all the time. Now, once you've got the protocols in place, I think it is critical that you understand how to interpret these studies appropriately. These are not easy studies to look at. There's a lot of information, a lot of potential diagnoses that you have to think about. And if you're not taking an algorithmic approach where you're considering all of the possibilities, I promise you, you're going to miss major diagnoses. So when I'm looking at these studies, I really have 4 steps. Goal number 1, you're obviously going to look for sites of active extravasation, which is the fundamental reason you're doing the study. Goal number 2, you're looking for vascular anomalies that may explain the patient's bleeding, even if there is no active extravasation, whether it's an AVM or angiodysplasia. Goal number 3, even if you don't see active extravasation, you're looking for other infectious or inflammatory causes of bleeding, whether it's enteritis, colitis, C. difficile, ischemia, and so on and so forth. And then finally, although rare, you don't want to miss one of those cases where there's this tumor of the bowel that's causing the bleeding. So you're going to run the bowel and look for a small or large bowel tumor. So why don't we start with goal number 1, which is probably the fundamental reason why these studies are ordered, and that's to look for active sites of extravasation that might help you guide further treatment. Now, active extravasation in the bowel is going to look just like active extrav anywhere else. You're looking for focal high attenuation material, typically following the blood pool, usually over 90 Hounsfield units. The morphology of the active extravasation will vary depending on the rapidity of the bleed. So slow bleeding tends to look more cloudy and amorphous, whereas faster bleeds can look more linear, and in some cases can even result in a contrast level within the bowel. In certain cases, I've even seen really fast bleeds that have completely filled the lumen of the bowel, and for whatever reason, that tends to be confusing for radiologists. We're used to looking for small focal sites of extravasation, but we tend to miss the huge bleed that's staring right in front of us. It is critical that you do not mistake high-density material in the bowel for active extravasation. Remember, the patient is not prepped prior to the study. They may have eaten something that's hyperdense, they may have an old suture line from surgery, or they may have taken a medication. This is one of the reasons why you need at least 2 phases. Now, if you acquire non-contrast images as one of those phases, this tends to be pretty easy, right? You just constantly cross-reference the non-contrast and post-contrast images, and you make sure that anything that you suspect potentially could represent an active extravasation wasn't there in the non-contrast images. But that being said, in this day and age where we're trying to get maximal information for the lowest radiation dose, I would argue that you're probably just as well off getting an arterial and a venous phase. The venous phase is going to give you more information regarding the solid organs, so you can make you can make findings outside of the bowel in the liver, the spleen, the pancreas, and so on and so forth. But you're still going to have a pretty easy time differentiating a true bleed from old hyperdense material. Remember, if you have 2 phases, a true bleed is going to increase between the 2 phases in size and should change in morphology. Anything that stays the same between the arterial and the venous phase is not an actual bleed. So here's a good example of an active bleed. You can see in the left colon that there is a small jet of contrast that is pretty subtle on the arterial phase, but it is enlarged considerably on the venous phase images. So a classic finding, you can see that it's changing in size and changing in morphology. Now, interestingly, this patient had a tagged RBC scan that was completely negative. Now, I will tell you the data in the literature, based primarily on animal models, suggests that tagged RBC scans are slightly more sensitive for bleeds than is a CT scan, probably by an order of 3, right? 0.1 cc's per cc per second, cc per minute, as opposed to 0.35 cc's per minute. But that being said, I've seen several cases now where the tagged RBC scan has been negative and the CT scan has been positive. So I think there is a subset of patients where CT may actually be slightly more sensitive. Now, as I mentioned before, these can be quite subtle. If you purely rely on the axial images, it can be quite difficult to identify some of the smaller bleeds. Now, I'm a big proponent of 3D imaging, but I think that's doubly true when you're looking at a GI bleeding study. Coronal MIP reconstructions are absolutely vital, and I've seen several cases where it saved me. Here's an example of one of them, right? There's a pretty subtle bleed here in the small bowel, deep in the pelvis. It's getting bigger between the arterial and the venous phase. Now, it's pretty obvious when you're looking at it like this. I've showed you the image where there's a bleed, but imagine scrolling through the entirety of the small and large bowel and trying to find this small dot of contrast extravasation. But notice how easy it is on the reformats, right? There's clearly a site of extravasation, and it's clearly getting bigger between the arterial and the venous phase. Difficult diagnosis on the axials, pretty easy diagnosis when you have the MIP reconstructions. Here's another example. Notice that there's a bleed in the left colon. Notice that it's getting bigger between the arterial and the venous phase. Now, this is one of those findings which I think radiologists miss. And I've seen this where radiologists are keyed in for looking at that linear jet of contrast, but we tend to miss the big finding. There's a big contrast level in the left colon that's getting bigger between the 2 phases. And for whatever reason, our mind tells us, well, it can't be a bleed. It's too big. It's probably old barium. But it's not barium, right? This is getting bigger between the 2 phases. This is actually active extravasation. So don't just look for small things. Look also for the larger findings that your mind has a tendency to overlook. Now, I will admit, it's easier to find these bleeds when they're in the large bowel. Small bowel bleeds can be quite difficult, but you've got to really take the time to look at the small bowel in quadrants. Divide the abdomen into 4, look at each quadrant in detail, and try to find those subtle sites of extravasation. Here's an example in the right lower quadrant ileum. There's a small site of active extravasation that's getting bigger. It's changing in morphology, and notice how it's actually moving as a result of small bowel peristalsis. Now, there are going to be cases where you're not going to see active extravasation, but you might still be able to, with reasonable certainty, figure out where the bleeding is coming from, and that's using the sentinel clot sign. Now, we all learned about the sentinel clot sign when we were learning about trauma, right? So if you have blood around the liver, you have blood around the spleen in the setting of trauma, the highest density blood typically is going to show you where the bleeding is coming from. So if you see the highest density blood around the spleen, even if you don't see a splenic laceration, you got to be worried that you're dealing with an occult splenic laceration, a splenic injury. The same thing holds true for the bowel. Even if I don't see active extravasation, if I see hyperdense clotted blood within the small or large bowel, that is probably where the bleeding is coming from, even if I don't see active extravasation. Here's an example where you don't need the sentinel clot sign, but I think it nicely illustrates the finding. There's a site of active extravasation in the duodenum, but notice how there's high density clots surrounding the active extravasation, classic sentinel clot sign. Now here's an example where it actually does help you quite a bit. I don't see active extravasation. Unfortunately, we're kind of limited by the fact that this is just a venous phase, but notice that there is high density clot layering within the stomach. This was a gastric bleed that was actually confirmed at endoscopy. And sometimes you can use the sentinel clot sign even in cases where you haven't given IV contrast. This is a patient who has horrible GVHD. The bowel looks incredibly thickened. The patient's really sick. They had lower GI bleeding. Notice how there's high density blood products throughout much of the small bowel. This patient has multifocal bleeding, not just a single site, but bleeding from multiple sites in the small bowel. Now, how do I approach these cases? I try to make sure that I haven't missed any portion of the bowel. Now, the large bowel is pretty easy. I always start with the large bowel since it accounts for about 90% of all lower GI bleeds, and I run the bowel from the rectum all the way to the cecum on both the arterial and the venous phase. And anytime there's an area of suspicion, I'm going to cross-reference with the other phase. The small bowel, as I mentioned, is harder to look at. There's a lot of it, harder to just run it in contiguity, but I typically divide the abdomen and pelvis into 4 quadrants and focus in on the small bowel in each of those 4 quadrants. Now, small bowel bleeding isn't that common, but it does account for about 10% of all cases, and probably a disproportionate number of cases that I see on CT for whatever reason. Now, once you've looked for active extravasation and either found it or not found it, your job isn't done, right? You're moving on to goal number 2 or step number 2, and that's to look for vascular anomalies that might potentially explain the patient's bleeding. Now, there are a number of anomalies you're going to look for, but I'd say the most important are going to be angiodysplasia, AVMs, and varices. Now, angiodysplasia is actually relatively common, although I think we tend to underdiagnose it or miss it on a CT scan all the time, right? It accounts for about 6% of all cases of lower GI bleeding, but is much more common in elderly patients where it probably accounts for a disproportionately larger percentage of GI bleeding cases. Now, angiodysplasia represents an abnormal proliferation of venules and capillaries purely within the submucosal layer of the bowel. It is degenerative and is related to those blood vessels degenerating over time as a result of aging. Now, unfortunately, this is one of those situations where colonoscopy is insensitive, identifying only about 2/3 of all cases that are ultimately seen on angiography. So as a result, I would argue that this is one area where CT can clearly outshine colonoscopy, provided that you take the time to look for the diagnosis. So what are you looking for? You're looking for densely opacified and dilated early draining veins, a large hypertrophied feeding artery, and a submucosal tuft of abnormal vasculature in the wall of the colon. So it goes without saying that the arterial phase images are fundamental to making this diagnosis, and a lot of these findings are going to be much less apparent when you use the venous phase. So here's an example which, believe me, is very easy to miss if you're not creating MIP reconstructions. You're in the arterial phase. Notice the hypertrophied artery feeding the right colon, the large early draining vein, and then this tuft of abnormal vessels within the right wall of the right colon. Classic angiodysplasia, and this is actually the classic location. The right colon is the most common location for angiodysplasia. Here's another example. Again, notice the abnormal tuft of vessels within the submucosal layer of the right colon. Always focus in on the right colon in these patients because that's where you're more likely to see angiodysplasia. Now, AVMs are, again, an underdiagnosed but still relatively uncommon cause of GI bleeding. Now, it's thought that of the 5% of all patients who have lower GI bleeding without ever having a source identified, that a substantial percentage may have an undiagnosed AVM. Now, these again are fundamentally a vascular anomaly, but unlike angiodysplasia, which just involves the submucosal layer, AVMs involve all 3 layers of the bowel wall: the mucosa, the submucosa, and the muscular layer. Now, AVMs can be found anywhere, classically in the small bowel, especially in the left upper quadrant jejunum, but can occur in any location. And honestly, even though the textbooks will tell you it's a small bowel, in my experience, I've diagnosed this most often in the rectum. And I don't know if that's anecdotal, maybe it's because we're more likely to look at the rectum carefully, or maybe this is really a place where it's unusual, where it's more common. Now, AVMs in the bowel look just like AVMs elsewhere. You're looking for an abnormal communication of arteries and veins, a vascular nidus, and an early draining vein. So you may ask me, how do I tell an AVM apart from angiodysplasia? And the answer is, it's not always going to be clear on a CT scan. Yes, if you see a big vascular malformation involving the entire bowel wall extending into the mesentery, you're probably dealing with an AVM, not an angiodysplasia. But there's quite a bit of overlap in terms of the imaging appearance, and ultimately it doesn't matter. As a radiologist, provided that you can make it clear that there is some kind of a vascular anomaly occurring in the bowel, you're going to be able to give the interventional radiologist the information they need to target that abnormality. So here's an example. As I mentioned earlier, most of the AVMs that I've seen in my practice have been in the rectum. Here's an example where there's an early draining vein, a tangle of vessels within the wall of the rectum, and this large hypertrophied feeding artery. Notice that it's much easier to make this diagnosis on these MIP reconstructions, or these 3D reconstructions with VR, but it's actually relatively subtle when you just look at the source axial images. Here's another example. Again, tangle of vessels, early draining vein, hypertrophy feeding artery, rectal AVM confirmed at angio. And here's one of the better examples I've seen. Classic features of a rectal AVM. This was actually ultimately confirmed at angiography. Now, the final vascular anomaly that you need to be cognizant of and always thinking of, especially in patients who have cirrhosis and portal hypertension, is portosystemic collaterals or varices. Now, the most common location in the bowel or in the colon is going to be the rectum, and the prevalence may be as high as 3/4 of all patients who have portal hypertension. Now, despite the fact that rectal varices are pretty common, it is worth noting that in the vast majority of patients, they're not going to cause bleeding. And even when they do cause bleeding, it's a venous bleed, so you're not going to see active bleeding or extravasation on the CT scan. But that being said, if I see a patient who has a reported history of lower GI bleeding, I don't see anything else on the CT scan but the presence of varices in the rectum, you have to at least raise the possibility that this could potentially represent the source of the patient's bleed. What are you looking for? You're looking for varices just like you would be anywhere else. Serpiginous vessels in the wall of the rectum or surrounding the rectum. They don't enhance on the arterial phase. They enhance on the venous phase. There's no evidence of a discrete early draining vein or vascular nidus, so they're not going to look like an AVM or angiodysplasia. Here's a patient with cirrhosis and portal hypertension. You can see these tangled vessels in the rectum, only visible on the venous phase, not seen on the arterial phase. Here's an even better example. Clearly cirrhotic, clearly has portal hypertension. Notice these dramatic varices surrounding the rectum in this patient who is presenting with signs of lower GI bleeding. So the next step is really, I think, one of the true strengths of CT, and that's it offers you the ability to make a number of diagnoses even in patients who don't have active extravasation. So I can tell you abnormalities in the bowel that could explain the patient's symptoms even if I don't see an active site of contrast extravasation. Now, clearly there are innumerable different diagnoses that you could make, but I'm just going to focus in on a few that occur in unique age groups. So we'll start by talking about the two most common, I think, all-comers, regardless of age group, and that's diverticular disease and infection. We'll then talk about a couple of diagnoses that tend to be much more common in patients who are really sick, patients who come into the ICU, and that's ischemic bowel and aortoenteric fistula. We'll then talk about a few diagnoses that tend to be more common in young patients, in particular inflammatory bowel disease and Meckel's diverticulum. And then finally, we'll talk about a diagnosis that you should look for in the elderly, and that's stercoral colitis. Now, diverticulosis is incredibly common, right? I probably see it in every other scan I look at. Its incidence increases substantially with age, and I think we don't tend to realize, but it is a very common cause of bleeding in the elderly. Now, even though we tend to think of diverticular disease as no big deal, it's worth noting that diverticular bleeds are usually arterial and can therefore be massive and severe. So in those cases where you see lots of diverticular disease but nothing else on the CT scan, you have to point out the diverticular to the clinician, as this could suggest the underlying cause of bleeding. Now here's an example where you have a sentinel clot within a diverticulum, right? So you know that this is why the patient is bleeding. There is hyperdense clotted blood within a diverticulum, and this was ultimately confirmed at colonoscopy. Here's another patient where you can see on the contrast-enhanced arterial phase study that there is active extravasation into a diverticulum. Remember, these are arterial bleeds, tend to be most evident when you see active extravasation on the arterial phase, can be very brisk and can be life-threatening. Here's another example. Again, active extravasation directly into a diverticulum. Notice how it's enlarging and changing in morphology between the arterial and the venous phase scans. Now, another very common cause, and I'd say one of the most common causes we see, is going to be infections. So when I see a patient who has lower GI bleeding, there's no active extravasation, I'd say one of the most common diagnoses that I'm able to offer the clinician is the presence of an infection, either of the small or the large bowel. Now, obviously, bowel infections are a very common cause of diarrheal illness in the United States, but the vast majority are not going to get a CT scan, and thankfully so, right? But that being said, it is important to remember that bowel infections can present with GI bleeding. Any bowel infection can actually do so, although there are certain infections or certain organisms that are more likely to cause lower GI bleeding than another. Now, when you're talking about large bowel infections, obviously there's a large number of different entities you could be thinking of, but when I'm dealing with a lower GI bleed and I see a large bowel infection, most often it's going to be C. difficile colitis. Now, classically, this occurs in patients who have recently been treated with antibiotics or chemotherapy and can be a fulminant colitis, high morbidity and mortality, and not uncommonly will present with lower GI bleeding. The classic presentation is going to be a pancolitis, involvement of the entire bowel with extensive pericolonic fat stranding, free fluid, and inflammatory change. So here's a patient who unfortunately we gave positive oral contrast to, was presenting with lower GI bleeding, but you can see there's a pancolitis, extensive submucosal edema, sick in the hospital with recent antibiotics. This turned out to be C. difficile. Here's another example. Again, lower GI bleeding, accordion-like wall thickening of the transverse colon, C. difficile colitis. Now, small bowel infections can also result in lower GI bleeding. And unfortunately, in most instances, you are not going to be able to make a specific diagnosis as to the pathogen based on the CT findings, but it is worth noting that the distribution of bowel involvement can at least suggest an underlying organism. For example, Giardia tends to involve the proximal small bowel in the left upper quadrant, whereas things like TB, Yersinia, Shigella, Campylobacter more often involve the cecum and the distal small bowel. I would argue in a patient with GI bleeding and thickened small bowel, infection should always be on your differential diagnosis, especially in cases where there's underlying immunocompromise or HIV. So here's an example of a patient who has a small bowel enteritis. Here's another example of a patient with small bowel enteritis. You're not going to be able to make a specific diagnosis as to the entity based on these cases, but of course in a patient with lower GI bleeding, you're going to at least be able to offer the possibility that this could represent infection. As I mentioned, sometimes the distribution can be helpful. Here's an example of a patient with cecal and distal small bowel wall thickening, GI bleeding. This turned out to be typhoid in a patient who had actually traveled abroad. Now, when you're talking about lower GI bleeding in a patient who's acutely ill, really sick, coming into the emergency room, maybe they're in the ICU, the two diagnoses I want you to think about are acute mesenteric ischemia and aortoenteric fistula. Now, mesenteric ischemia not uncommonly will present with acute GI bleeding, probably about a quarter of all cases. These patients classically will have abdominal pain out of all proportion to clinical exam. Now, there really are four underlying causes of mesenteric ischemia. The most common, at least if you look at the literature, is arterial occlusions, typically as a result of emboli to the SMA or smaller SMA branches. Usually from the heart, although can also occur in the setting of significant ulcerated atherosclerotic plaque, and in very rare instances can occur as a result of thrombosis of the SMA resulting from atherosclerosis or hypercoagulability syndromes. Less common is venous occlusion, classically SMV thrombosis, which accounts for about 10% of cases, and I would say tends to be most common in patients who are hypercoagulable, who have recently undergone surgery, or who have septic thrombophlebitis related to acute GI tract infections, appendicitis, diverticulitis. These patients tend to have a more indolent presentation, often don't come to clinical attention promptly, and accordingly have a higher than expected mortality rate of about 40%. Now, the third cause is one that's probably underdiagnosed, and that's non-occlusive mesenteric ischemia. Typically occurs in patients who are hypotensive with diminished blood flow to the bowel, could be an MI, could be cardiac failure, severe hypovolemia, overdiuresis, and so on and so forth. These patients are sick, they're in the ICU, and not surprisingly, very high mortality rate. And then finally, something that I think probably accounts for a greater percentage of these cases than is popularly reported, and that's complicated bowel obstructions, typically closed loop obstructions or internal hernias. And the key in these cases is to differentiate a simple small bowel obstruction from one of these complicated bowel obstructions that have underlying ischemia. Now, it is worth noting that each of these 4 different causes of bleeding is associated with unique CT findings, although, of course, there is a great deal of overlap. It is worth noting that patients with an arterial occlusion, so an SMA embolus or an SMA thrombosis, do not classically have a lot of bowel wall thickening or mesenteric edema or stranding, but rather will have thinning of the bowel wall, typically with bowel wall hypoenhancement. So these can be quite difficult cases to identify. And this is one of the reasons why that dual phase technique, using arterial and venous phase imaging, can be quite helpful, because I've found that identifying that bowel wall hypoenhancement is usually easier on the arterial phase. Venous occlusion tends to be much easier to diagnose, right? You see the SMV clot, and you see dramatically thickened, hyperemic, inflamed bowel, usually with lots of mesenteric edema, hemorrhage, and stranding. Now, non-occlusive mesenteric ischemia does not have a consistent pattern. It can look either like an arterial or a venous occlusion. And really, the key to this diagnosis is understanding the patient's history and putting that together with the presence of either bowel wall hypoenhancement or abnormal bowel wall thickening. And then finally, complicated small bowel obstructions. Hopefully, the bowel obstruction will be obvious. Look for signs that you're dealing with a closed loop obstruction, radiating, tethered loops of bowel, and it can have features of either or both arterial and venous occlusion, because after all, the reason for the ischemia is strangulation of the arterial and venous blood supply to the bowel. Here's an example of arterial occlusion. There's an SMA embolus, and you can see that the small bowel is diffusely hypoenhancing. There's really very little bowel wall enhancement. This is acute mesenteric ischemia. Here's another example. This patient has clot in their SMA, as you can see. Much of the small bowel is non-enhancing or hypoenhancing, and you can juxtapose that abnormally enhancing bowel with a more normally enhancing bowel in the left upper quadrant. Again, arterial occlusion-related mesenteric ischemia. Now, venous occlusions tend to be much more obvious, and the key here is not that you're going to miss the bowel findings, but the key is that you don't miss the presence of clot in the SMV. In this case, horrible-looking bowel, lots of mesenteric edema, hemorrhage, and there's clot in the SMV. Here's another example. Again, dramatically thickened, dramatically hyperemic bowel in a patient with SMV thrombosis. Here's an example of a patient with ischemia related to a small bowel obstruction. This was an internal hernia resulting in a closed loop. And notice that there are features of both arterial and venous occlusion. The bowel loops in the right hemiabdomen are abnormally hypoenhancing, which is what you'd expect with an arterial occlusion, whereas the loops in the left lower quadrant are thickened and hyperemic, features more commonly seen with a venous occlusion. Remember, you can see features of both arterial and venous occlusion in these cases because both portions of the blood supply are going to be strangulated, both the arterial and the venous. Finally, non-occlusive mesenteric ischemia can look like anything. The key here is to understand the patient's history. This patient is in the ICU. They've just been coded. They have been hypotensive. Put that together with a thickened bowel, and you can diagnose the presence of non-occlusive mesenteric ischemia, or NOMI. Now, the other diagnosis I want you to think about in patients who come into the hospital with lower GI bleeding but are acutely, life-threateningly ill is an aortoenteric fistula. Now, this is a rare diagnosis, but one that, if you don't make the diagnosis appropriately, will kill the patient. Now, even if you do make the diagnosis, admittedly, these patients have sky-high mortality rates that may approach 100% even with treatment, but any chance they have will be contingent on you making the diagnosis on a CT scan. Now, most of the cases of aortoenteric fistulas that I see in my practice are secondary. So these patients have had some kind of prior aortic surgery, whether it's a graft placement or stent. And patients typically come in with massive abdominal pain and massive lower GI bleeding. Now, there are other options, angiography and so on and so forth, but ultimately I would argue that CT is the best modality for these patients initially. And what are you looking for? Well, you would think that you'd be looking for contrast extravasation from the aorta into the bowel or vice versa, but the truth is you almost never see that. In fact, I don't think I actually have seen a case where I've seen contrast going directly from the aorta into the bowel, or maybe I've seen one case. What you're looking for rather is secondary findings. And the most important of those is ectopic gas either within the lumen of the aorta or immediately adjacent to the aorta with surrounding fat stranding and effacement of the fat plane between the aorta and the adjacent bowel. Here's a great example. This is a patient who you can see has clearly had prior aortic intervention. The aorta is massively dilated, but note the critical finding. No fat plane between the duodenum and the aorta, and there's gas directly tracking from the duodenum into the aorta, classic aortoenteric fistula. Now here's a more subtle case, or a couple of more subtle cases. Notice in both of these instances there is abnormal gas located within the aortic lumen. These patients have had prior aortic intervention. These patients both had aortoenteric fistulas. Finally, let's talk about a diagnosis that you should be thinking about when you're dealing with an elderly patient, and that's stercoral colitis. Now, what is that? I got to be honest, when I bring up this diagnosis with my residents and fellows, I would say that probably 3/4 have never heard of this diagnosis, and most look at me like, why are you talking about rectal impaction? This patient has GI bleeding. Why are you wasting time? And the truth is that this is a critical diagnosis that we as radiologists just tend not to make because we think it's an irrelevant finding, right? And that is over-distension of the rectal lumen with formed impacted stool. We all see constipation, but how often do we actually report it in our dictations? And the honest truth is that it is something you should be reporting, especially in elderly patients who come in with unexplained lower GI bleeding. Now, over-distension from this formed fecal material, when it gets severe, can cause increases in luminal pressure and can ultimately result in rectal wall ischemia by disrupting the blood supply. Now, over time, that disrupted blood supply will result in ulcers of the rectal wall and can ultimately result in bleeding. And in fact, the dreaded complication is perforation, and I've seen patients actually die from this. So this is not a diagnosis to make light of. It is a diagnosis that must be made by the radiologist. Now, these tend to be relatively slow bleeds. You're almost never going to see active extravasation, but it's the finding of the impacted rectal vault with lots of formed fecal material that should allow you to make the diagnosis. Now, in patients who actually have clinical symptoms, either pain, maybe the earliest signs of perforation or bleeding, you're typically going to see some thickening of the rectal wall as well as some subtle perirectal stranding. Now, almost always this is an entity that you're going to see in elderly patients. So this is not an entity you're going to see in a 30-year-old. It's classically a 70-year-old, usually in a nursing home or long-term care facility, and they're unable to verbalize to their caregivers that they have rectal impaction. Here's an example. This patient had lower GI bleeding. Notice the massive amount of stool descending the rectum, probably about 10 centimeters in diameter. It's formed hard of fecal material, and there's subtle rectal wall thickening, maybe a subtle amount of fat stranding around the rectum. I actually recommended to the ER physician that they disimpact the patient. Now, I know ER physicians may not like hearing that from a radiologist, but the truth is you really want to be very explicit to the physician that this does place the patient at risk for GI bleeding and perforation. Here's another example. Again, thickened rectum, subtle stranding, formed hard fecal material distending the rectum. You want to recommend disimpaction. Now, what are some diagnoses you want to think about in young patients who present with lower GI bleeding? And the two diagnoses you want to think about are inflammatory bowel disease, which presents with bleeding in almost every patient who has ulcerative colitis, and a sizable percentage, maybe about 1/4 of patients who have Crohn's disease, and in both cases can present with acute severe hemorrhage. Now, the other diagnosis you want to look out for, which, to be honest, and admittedly is very, very difficult to make prospectively, and that's a Meckel's diverticulum. And these patients will often present with painless lower GI bleeding, typically in the pediatric age group. Now, inflammatory bowel disease is not typically a difficult diagnosis. Crohn's disease, you're looking for thickening, hyperenhancement, classically the distal small bowel extending into the terminal ileum, engorgement of the vasa recta. Ulcerative colitis, you're looking for wall thickening extending proximally from the rectum. No skip lesions, tends to be relatively contiguous. In most cases, these patients have a known history, and even if they don't, the patient's age, their demographics, and the distribution of the disease should allow you to at least suggest this as the underlying diagnosis and the cause of the patient's bleeding, even if you don't see active extravasation. I will admit, Meckel's diverticulum, not an uncommon cause of lower GI bleeding in children, but extraordinarily difficult to make as a diagnosis. Here's an example of a case actually diagnosed by one of my colleagues. And you can see that there's a small outpouching from the distal small bowel. There's a sentinel clot sign with high density hemorrhage within the diverticulum. This patient was presenting with lower GI bleeding. Oftentimes, these can be virtually impossible to identify unless there's inflammation. Here's a case where the patient has, an inverted Meckel's diverticulum with diverticulitis. And so in a case like this, you're going to be able to make the diagnosis. But, a colleague of mine, Satomi Kawamoto, she has an article coming out in press soon in AJR where she and I looked at a bunch of these Meckel's diverticula in retrospect, even knowing that they were there based on surgical resection. We had trouble finding them on a CT scan. So I would say take the time, look at the distal small bowel, trying to find these in young patients who have unexplained lower GI bleeding, but even so, you're going to have a hard time finding many of these. So what's the final step? The final step is to look for a tumor. Now, I think people overrate this, right? People assume that cancer is a major cause of acute lower GI bleeding, and the truth is that it's not, right? It accounts for less than 10% of bleeds in patients over the age of 50, and when it does occur, almost never presents with acute bleeding. It's typically chronic occult bleeding. But in theory, any tumor in either the small or the large bowel can present with GI bleeding, and so it does have to be a part of your search pattern. Now, hopefully, none of you would miss something as large as this. Here, there's a huge mass involving the sigmoid colon. Patient had lower GI bleeding. Not difficult to put two and two together. This patient has a cancer that's causing the GI bleeding. But you do need to take the time to look for more subtle sites of tumor, such as this. Here are two cases, one with a tumor in the distal transverse colon on the right, and the other with a right-sided colon cancer on the left. And in both cases, I think pretty easy to overlook if you don't include this as part of your search pattern. So you really do need to look at the large bowel for that occult colon cancer, and look at the small bowel as well. Here's some examples of small bowel tumors. The first is, I think, a duodenal gist tumor on the left, and the example on the right is a distal ileal carcinoid tumor. Both patients were presenting with GI bleeding, and if you don't take the time to look, you're going to miss these cases. So in conclusion, hopefully I've managed to convince you that MDCT is a good and excellent option in the setting of acute GI bleeding, and I would argue that it really should be the first-line modality when you're evaluating a patient with a lower GI bleed. Not only do I think it gives you much more information than any other radiologic modality, I would argue that it's probably a better first step even compared to colonoscopy. But if you are going to use this in your own practice, protocol design is critical. You've got to be acquiring at least two phases, arterial and venous phase, or non-contrast and post-contrast, because without the right protocol design, you are not going to be able to make the diagnosis, and you're not going to be able to distinguish intrinsically high-density material in the bowel from a true site of active extravasation. Finally, these are complex studies. There's lots of findings that you're looking for. Utilize an algorithmic approach. Make sure you're looking for each of the different findings I talked about earlier. Look for active bleeding. Look for vascular anomalies like AVMs or angiodysplasia. Look for other infectious or inflammatory causes of bleeding, such as ischemia or infection. And then finally, look for that rare cause of an occult small or large bowel tumor that's causing acute bleeding. That's all I have. Thanks again, and I'll catch you guys later. Bye.